I have not changed. No. So that's, so if you see the,
Can you show that first image, the very first guide wire? Yes. This looks a little deceptively close to the ICL line. But
that's correct, because that's you're seeing, that's because you're seeing it in the AP, but see it in the lateral.
And can you show the next AP view? It seems to be a little distal, or maybe it's the trick of the projection.
It is a flexed view. I have look at the overlapping of the tibial condyles now, and now check the overlapping of the tibial condyles. So I've kept a bump and I've flexed the knee to 20 degrees. So when you're drilling this, do an intercondylar notch view. So when you are doing a distal femoral fixation, a DFO, you want to flex the knee to 45 degrees to get a good intercondylar notch view. So this is where you see it. You put the guide wire with the knee in about 10 degrees of flexion so that you get your entry point, and then you bring it to an intercondylar notch view where you can see the intercondylar notch, and then you can see that you're avoiding the physeal plate properly. And of course, the final confirmatory test is that you do an arthroscope, you put your arthroscope in the socket, and if you see that you violated the physis, then you will see the cartilage ring seen right there. Then obviously you want to go ahead and do the tibia, and this is an arthroscopic view of the tibia, and then you go ahead and pass your graft depending upon if you're doing a closed socket or if you're doing what was I saying, if you're doing a closed socket or a tunnel. So I did a tunnel for this patient, and the graft can be pulled from the femur to the tibia, or you can pull it from the tibia to the femur depending upon which way you want it. And this is my graft going in. Yes, Rajiv.
Sachin sir, when you are doing a tibial tunnel,
Yeah.
so do you check it with CM, because other again
So
tibial
for
physis
this
is also
patient,
wavy.
because I did not do a physeal sparing tunnel on the tibia, I did a transphyseal tunnel. So if you're doing a transphyseal tunnel, you should move close to the midline, and you should have as vertical a tunnel as possible, because the physeal plate comes down as a tongue, and if you go closer to the midline, if you drill perpendicular to the physeal plate, you will get a round hole. If you drill oblique to the physeal plate, you will get an oval hole. So the inclination matters on the amount of injury to the physeal plate. So I did a transphyseal drilling here. If you want to do a physeal sparing, then you have to be absolutely medial to the tibial tubercle, and you have to again pass it under image intensifier to see how that wire is going. So point there, absolutely.
Sachin sir,
So your
what's your
plan,
okay.
your plan changes where suppose it's a 8-year-old child gymnastic player. So then you will drill through the physis, or you will go for
So
physeal
for
sparing?
an 8-year Tanner stage 1, maybe 1 going into 2, I will do a physeal sparing, a Staheli-Kocher technique, where I will have a strip of the ITB and I will bring it over the top, not drill any tunnels at all.
Yeah, I was actually going to ask what Rajiv was asking. What is the minimum age at which you will still do transphyseal on the tibia?
I will give you what my philosophy has been over the last maybe 20 years of looking at this. I'll come to that slide last.
Okay.
Sachin, when you're drilling from outside, and how when Raju does it as a socket, where would be your landmark be in terms of the lateral femoral surface? Because you got the popliteus, you got the lateral epicondyle, you got the FCL, and you're left with a very small space to work around with. So which would be your go-to zone? Would it be posterior to the epicondyle, or is it anterior? How do you work that out?
You look at the insertion of the FCL on the lateral femoral condyle, and proximal to that is your physeal plate. So you have to stay at or distal to the insertion of the FCL on the lateral femoral surface. If you start going proximal, towards the lemare point, that means you are at a higher risk to injure your physeal plate. So if I look at it on a lateral view, which is what you will do, that's your first Siam shoot that you do. You bring your knee in about 5 to 10 degrees of flexion, and you look where your FCL insertion is, put a small 18 gauge needle there and make a first shoot, and that will tell you how far proximal is the physeal plate from that point, and based on that you know what zone you can play in depending upon what diameter of tunnel you have.
So you're saying stay posterior to the epicondyle?
I'm saying do not venture
No,
proximal.
I can understand the proximal bit. That's in
Correct.
relation to the physis.
Correct.
But I'm talking about the surface area.
Anteroposterior location.
Anteroposterior location.
Anteroposterior location, I will be posterior to the insertion of the FCL on the lateral surface. Usually, yes.
So when you fix it when the tunnel is transphyseal on the tibia and it's fixed, is there a concern with the growth of the child or the adolescent, the graft gets stretched or something? One. And two, if you're doing all epiphyseal, then is there a role for this neo ligaments or not using graft at all?
Okay.
It won't stretch out as well.
Okay, so your second question is the easier question. Is there a question for any artificial ligament? Absolutely not. The child is growing, and if you put artificial ligaments, it is going to be a teether, and you will definitely land up with a growth
But
arrest.
it will be all epiphyseal on both sides.
Doesn't matter, but that graft is not going to elongate. It may get ligamentized, but it is going to be a teether. It is not going to allow the growth to happen, and it will definitely affect the physeal plate. If you use a transphyseal technique, so the graft elongation is an intra-articular elongation. Your graft will get ligamentized around 6 to 8 months. After that, what is there inside the tunnel is not consequential. Graft elongation will happen if you fail to treat peripheral lesions. It has got, and if you have poorly placed tunnels.
Sachin.
Yeah?
Would you ever do all transphyseal in any of your case?
Yes.
Like this is more of a hybrid.
Yes.
The thing with the hybrid is there's a lot of kiloturns, 90 and 90.
Yeah.
And second is whatever you do, the chances of re-tear is very high, so the revision would be difficult if you go for a hybrid.
Okay.
So what's your opinion about doing a all transphyseal along combining with some extra-articular procedure to prevent the rotational instability?
So that's a great question. So I add a modified Ellison's in most of these patients if they have a grade 2 pivot. But we still don't have a lot of data. There is one good systematic review on the addition of a lateral plasty. So whenever you see large meniscus tears, whenever they have pivot shift, add a modified Ellison. Don't do a Lemaire or a modified Lemaire. If you do a modified Lemaire, you have to stay distal to the physeal plate again. Okay? Or the other good thing is that when you prepare your graft, which I do in couple of cases as well. Prepare it so that you bring one limb of the gracilis down through your complete femoral socket, and then you fix it down in the tibia like an ALL which is passed underneath the FCL.
So my question was along the same line. So this is an adolescent hamstring graft, very high risk of failures. So would you recommend routine use of a lateral plasty in all these cases?
So the data that we have from, I think Leo Pincheski has the best paper on this, where he looked at 20-year survival rates of his ACL reconstructions. Adolescents who have slopes less than 12 degrees will have a re-tear rate of roughly around 20%, 15 to 20% at 20 years following their surgery. Adolescents who have slopes higher than 12 degrees have a re-tear rate of 68% at 20 years. So that's a huge number. Correct. So 2 out of 3 will tear.
Correct.
So look at your slope, but don't change the slope in a kid.
Yeah.
But definitely do a lateral plasty for them.
Now, Sachin, can you point out with a pointer where you would like the entry point of the tunnel on the screen? We have changed the screen, not on your screen, but on this screen, where would you like the entry point of the tunnel to be when you're doing a lateral sided to avoid the physis in a kid? Can we have the pointer given to Dr. Sachin?
So what we have here is that this is your FCL, correct? Your FCL insertion is right there. Your physeal plate and your perichondral ring is right here. So this is where your perichondral ring is, there. So this is your FCL. Now my first wire is not a wire but a 18 gauge needle which I place somewhere in between this area at 10 degrees of flexion on an AP C-arm view. That tells me approximately how much length I have to play in this area here. Let us assume it is about 4 millimeters, or let us say it is 10 millimeters, and I have a socket of 7 millimeters. So I know for sure that I will stay around this area and I will stay posterior to the FCL insertion so that I get a horizontal like tunnel. You'll have to turn it the other way around, Raju. You'll have to turn it the other way around. Rotate, 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 rotate. Yeah, perfect. So you want to stay more posterior. Can you get rid of these muscles? Go minus layer, minus layer. Yeah, take out all of these muscles now. Good. And the vessels as well. Remove everything. Yeah. Take out the veins as well. Great. And the nerves, we don't need them. Nerves are not good. Okay. So now what you have is that you have a horizontal tunnel, not totally horizontal, but a bit inclined, which comes down like this. Okay?
Sachin here. So in children, at the time of fixation, tensioning of the graft and fixation, that is very, very critical, because the children knees, there is lax, sometimes recurvatum, it will be mediolaterally lax and anterior-posterior lax. Do you expose contralateral side to see how much is the tension you need to give before fixing?
I think you have to treat them, your ACL tension. I will not leave it tensioned loose at any way. And I don't use adjustable loops on both sides where you run the risk of over tensioning. You're using a suspensory fixation on both the tibia and the femur, which is away from the physeal plate. So my tensioning is basically based on the range of movement. If they are hyperextending, then I tension it at 0 degrees. If they are neutral, I will tension it at 10 degrees.
I think we need you to finish. We'll ask maybe one or two
last
questions.
question.
Yeah.
Why don't we try all inside for the pediatric?
Of course, you can do an all inside. Absolutely no
it will
problem.
be more of physeal sparing.
So
no need to make tunnels at all.
Huh?
On the physeal area.
Exactly. So
that's another way.
Whether you want to drill through and through tunnels or you want to drill sockets, I mean, that's just the way you want to do it. So basically, it's all the same. Right. So what we know for sure is that if you do non-operative treatment, they have higher chances of doing poorly. So get to these patients early because we want them to return to sport. And again, you have good meta-analysis and systematic reviews that will show you that if you operate on them and get to them early, they will have a good success rate. So everybody is afraid of having growth arrest and growth problems. It is only if you put bone plugs, if you drill obliquely, and if you put artificial ligaments in the joint, so stay away from them. And there is so much of data that tells you that if you don't repair the peripheral lesions, and if you add an lateral plasty, then your revision rate can be as low as 6%, which is absolutely important. And again, you have to get to them early, don't get to them late, because if you get to them late, you are more likely to have meniscus tears, and these meniscus tears in kids will have a very drastic and very poor prognosis. So what do I do? This is what I follow. So if they have less than 1 centimeter of growth which is remaining, and if it's a female more than 13 years or a male more than 15, I'll just do an adult-like surgery. If they have 1 to 5 centimeters of growth remaining, and they have 11 to 12 years in a female or 13 to 14 years in a male, then I will probably do what I've done, which is a hybrid technique. If they have more than 5 centimeters of growth remaining and they are less than 10 years girl or a less than 12-year-old boy, then my choice is either do a physeal sparing, which is the Meninder-Kocher technique or Staheli-Kocher technique, or if you're feeling very confident, you can drill sockets and blind sockets or full sockets and do an all epiphyseal technique. So thank you so much.